We're going to move to our second presentation. So that means we are moving on to Erin, Bud, and Inderpal Dosanjh. And Inderpal is currently the clinical research coordinator with Fraser Health's Mental Health and Substance Use Department, focusing on strengthening capacity for impact-driven, patient-centered research. He completed his Master's of Public Health at Western University in London, Ontario. And Erin's and Inderpal's presentation is entitled A Mixed Methods Exploration of the Characteristics and Perspectives of Patients Utilizing the Virtual Health Addictions Care InReach Model. And Erin, I realize I don't have your bio. So if you guys, as part of it, want to just give a little blurb on your background, that would be great. So you guys want to share your slides and take it away.
Thanks. And Inderpal's manning the slides, so Inderpal, just say next. I have notes and Zoom.
Yeah, I have the slides up.
Okay, thanks.
Yeah, the slides are there sharing, so that's good. So we're ready.
Excellent. Shall we? Okay. I'll put a little timer on so we don't run into anyone else's. Here we are. Okay, so thanks very much for the kind introduction. Thank you all for joining and welcome to the 7:15 a.m. session in British Columbia, which is good. Inderpal and I will basically be discussing the context in which the Fraser Health Virtual Health Addictions Clinic came to be, and we'll share the results of the study focusing on hospital patients' experience of our VHAC service. Next slide, please. And also, hopefully to start our little session on a good note, this is the land acknowledgement from Surrey, British Columbia. We recognize that Fraser Health provides care on the traditional, ancestral, and unceded lands of the Coast Salish and Inkla-Katma nations, and is home to 32 First Nations within the Fraser Salish region. Fraser Health is dedicated to serving all Indigenous people and honors the unique cultures of the First Nations, Métis, and Inuit living within the Fraser Salish region. And seeing this land acknowledgement on a lovely sunny morning, whenever it's in the context of addiction medicine work, always makes me consider the idea of recovery. And in Fraser Health's, and I guess our perspective, recovery with the land. And so this idea that a common concept that comes up in addictions medicine is recovery, and what does that mean? And it seems to be moving most towards the idea of it being a journey that improves wellness and where people strive to reach their full potential, whatever that looks like. And so in Fraser Health, we're actually working on our relationship and recovering our relationship with our natural environment. And we've been engaging in recovery efforts. Not perfect for sure, but small changes in a good direction. And so I'm thinking about these lands and the plants and animals and soil and how, though we may have had an unhealthy relationship previously, there's hope that we can build a reciprocal relationship with the land that supports us. And that hope is certainly in no small thanks to First Nations teaching, sharing of knowledge, and sharing of values. And for that, I'm very grateful. Next slide, please. So disclosures of financial support. Inderpal and I both declare that we have no conflicts of interest or financial support to disclose. Maybe one day. Until then. Since I did not send my bio in obviously in a timely fashion, my name's Erin, Bud. I'm a family physician who and also working in addiction medicine. I finished my training in Ontario, came out to British Columbia to do just a few months of extra training and have stayed for 5 years. For now, anyways. I work in the Virtual Health Addictions Clinic. I work at one of our rapid access to addiction care clinics, I believe the British Columbia equivalent to a RAM. And I work at Fraser Health's Medical Withdrawal Management Center, so our health authority detox, and I also work in primary care. And Inderpal, if you want to say hi.
Hello, everyone. I'm the research coordinator at Fraser Health.
Thanks. Next slide. So Fraser Health. For those of you who aren't familiar with Fraser Health, our health authority covers a large geographic area. It's about 200 kilometers from Burnaby on the left side of the screen. And then you go all the way, you see Fraser Canyon Hospital to the right, keep going, and there's a place called Boston Bar, and that's our area. recognizing where MetaPHI is being hosted. That's about from Toronto to Huntsville. And it's about 1.7 million people in the catchment area. It's beautiful country, but unfortunately, the rates of drug-related harms and unregulated drug deaths in our health authority are among the highest in the country, with more than 700 deaths last year. Next slide, please. So, as illustrated by that map, Fraser Health covers a large geographic area, and residents bear a substantial burden of drug-related harms. The context in which VHAC was envisioned was keeping in mind that geographic area and recognizing that the lack of addiction medicine physicians and inequitable access to physicians and to addiction medicine expertise and care were apparent. And then in 2020, with the COVID-19 pandemic, there was an increased rate of overdose and also a new need to support people to self-isolate. Given these urgent priorities, the Virtual Health Addictions Clinic was created. Because of the dual public health emergencies, the COVID-19 pandemic and the opioid overdose epidemic, the implementation was expedited. So this actually was implemented faster than it would have been otherwise. Our first areas of care were COVID isolation centers. So these are people with no fixed address or unstably housed, and they were provided accommodation in repurposed buildings to support self-isolating. And we would video call to outreach workers with the goal of connecting with patients and ensuring things like opioid agonist therapy were assertively up-titrated and utilizing whatever other tools we had at our disposal, such as hydromorphone pandemic prescribing, to try and support people and manage withdrawal and cravings while they were self-isolating. Next slide, please. We've come a long way. So VHAC now provides virtual consultations in a variety of locations. So the COVID isolation centers are no more. But we work in outpatient settings. So we might provide opioid agonist therapy prescriptions. And we do see a range of addiction medicine presentations. So we also might see people with different substance use disorders. So we might be supporting people with alcohol use disorder and withdrawal management, relapse prevention, those kinds of things. And for hospital inpatients, we support the most responsible physicians in hospital with withdrawal management and consults for patients with opioid use disorder. And we can be a connection to other services, so we can recommend psychosocial supports, but also we play a significant role in assessing people for medical detox. So in Fraser Health, there's one medical detox across the region. And because it's such a limited resource, we utilize eligibility criteria to help determine if this is a recommended course of treatment. And if so, we can provide the addiction medicine referral that the service requires. Next slide, please. So this is a visual representation of our service. We follow a hub and spoke model. So we receive referrals from all these different areas. So firstly, we receive we receive referrals from hospitals that don't have an addiction medicine consult team. We call it InReach. Because as MDs, we're not privileged at every hospital. We don't actually write orders, but we'll video consult with patients, and then we'll communicate with the MRPs at recommendations, and we can support them to implement them. We are currently at 7 hospitals, and we plan to expand to 10. We have multiple rapid access to addiction medicine care clinics across the region, and these are variably staffed. So if there's no doc or a high volume of patients, we can see patients there. And this is the same with our regional OAT clinics. For example, there's no doc and someone needs a restarted prescription or a bridging prescription. And then finally, we're connected with Fraser Health outreach teams, such as our Integrated Homelessness Assessment and Response Team, or IHEART, as we call them, and we'll connect with people living in shelter or people who are unhoused. And overall, the goal of VHAC is basically to be a clinic that provides care that bridges the gap when an addiction medicine physician is not available on site, including in remote and rural communities and hospitals. And that's where we're at today. Next slide, Inderpal.
So thank you, Dr. Budd, for providing the overview on the VHAC service and providing the overview on the InReach aspect. So the next half of our presentation will dive into describing the demographic and clinical characteristics of VHAC patients, and also evaluating the patient's experiences that have used the VHAC delivery model. And we did that through a mixed methods approach. First, we obtained quantitative data from EMRs of 87 randomly selected patients that used the VHAC service, on which we then conducted a descriptive analysis. Secondly, we conducted semi-structured interviews with 9 purposefully selected VHAC patients to obtain qualitative data. And those interviews were guided by the PC Support Unit's patient-oriented research checklist. The data from those interviews was then transcribed and analyzed using a descriptive hemological approach to focus on describing their lived experience as perceived using the VHAC service. So in terms of sociodemographic characteristics of VHAC patients, the mean age of patients was around 41 years old. So most were in the 35 to 44 years range. Majority of the patients had previously used OAT, with methadone previously used by 73.6% of patients, and a majority identified themselves as male, were unemployed, and only a third had access to stable housing. Approximately half had previously experienced an overdose prior to using the VHAC service. So in terms of clinical characteristics, majority of patients that use VHAC were discharged on OAT, with the minority experiencing any adverse events. Specifics on those adverse events are outlined in the pie chart, and out of the small minority that experienced an adverse event, they primarily experienced precipitated withdrawal or sedation. At the time of discharge, 20.5% had experienced cravings, and 31.3% of patients experienced withdrawal. Overall, a majority of the patients completed their hospital stay with a median stay of 5 days, with most only staying 1 day at the hospital. From those 9 interviews that we conducted, there were 3 main themes that we identified. One was convenience and ease of access. 2 was high quality of care received. And 3 was greater comfort and safety using the VHAC service. So for the first theme, we saw convenience and ease of access, and most respondents indicated that the VHAC service was more convenient and accessible than in person. And respondents also mentioned that technology wasn't the barrier now that virtual meetings were a common feature of everyday life post-COVID. So I want to share a quote from a respondent. Quote, in person, referring to in person, is pretty inconvenient, considering that when I was at another clinic, they had to fly a man in from Prince George every week to get somebody a methadone script. So doing so virtually is pretty helpful. It's the convenience. And like to this generation, we live off Zoom. Another theme that we saw was high quality and care received. All respondents felt that they had been treated with respect by the physicians, feeling listened to, cared about, and that their needs were met. And I want to share a few quotes from respondents. The new doctor that I'm seeing, she's very helpful. She gives me great feedback. She gives me great feedback to me, and she pretty much gives me inspiration. Just telling me that I'm doing a good job, to keep trying. It's hard. The doctor, the virtual doctor, saying that I care, that I'm still a human being, that I have self-worth. And I want to share another quote. When somebody goes the extra mile too, it helps you feel you feel like you're worth it. Another theme we saw was greater comfort and safety using VHAC. All respondents described the virtual environment as comfortable and feeling at ease. There was one respondent that did indicate that they still wished an opportunity to see a provider face-to-face on occasion. So here's also a quote from a respondent. It's just like an ease, weight off your shoulders kind of deal. It's definitely a more pleasant option for somebody who's got social dysfunction, and they were referring to anxiety in that case. Overall, all respondents favorably endorsed the VHAC service. So in general, respondents felt open to trying the service when it was first suggested or proposed to them. None of the respondents indicated that they felt coerced or negatively pressured to use the service, and all felt that the VHAC process had been adequately explained to them. Additionally, respondents did not feel like the virtual environment offered by VHAC presented any notable loss of personal connection with their care provider, nor did it diminish the overall quality of care or service they received. In fact, all respondents described receiving as good, if not better, care through VHAC, and many indicated that they would recommend the service to others, or already had recommended the service to others. One respondent indicated that they would have ideally wished to have a bit more consistency with the physicians they saw, although they noted this wasn't a central concern for them. So overall, all 9 respondents described VHAC positively, and I want to share 2 quotes from respondents on their overall experience and general endorsement of VHAC. I was kind of curious whether it would work, but it seemed to work very good. I was able to get everything I needed. It was all good. Another quote. Personally, I think you guys are doing a bang-up job at VHAC. At first, virtual was obviously a little bit different, right? But I haven't felt any loss of doctor care or anything like that. You're getting no less quality care. In terms of future plans, there's ongoing work at Fraser Health to further strengthen our initial findings as additional data becomes available to make it more robust and for a future publication. And I'll also let Dr. Budd explain some of the other plans.
Thanks. Looking at the time, we'll wrap it up, but just recognizing that, yeah, we're going to expand our referral base to more hospitals within the health authority. And we also are starting to take referrals from the emergency room for patients who may or may not be presenting with a substance use related concern. But we have some addiction assessment nurses who basically identify someone who might benefit from an addiction medicine consult. Maybe they need an OAT restart, something like that. They'll liaise with the emerge doc, and if they agree, then they'll consult us that way. And also our health authority is going to be implementing kind of a one phone number, like a one entry mental health and substance use service delivery model. And so we'll be involved in that as well. So
Okay.
getting bigger every day.
Thank you very much, Erin and Inderpal. And we will go back to Mackenzie. I think Mackenzie is ready to roll. So we're going to just quickly go through questions. We have some good questions in the Q&A. So we'll go through those. And then if there is any time remaining at that point, we will go to anyone who has their hands up. And then at the very end, before you leave, in the chat, I will be putting the survey, the feedback survey for the session. So please don't forget to do that before you leave. So first, we have a couple of questions for Dr. Budd and Inderpal about the virtual nature of their services, and 2 kind of components to it. One was, how do you manage urine screens when we're doing a virtual clinic? And 2, challenges around, can you speak to challenges around virtual meetings, especially around clients' access to the internet and technology? So I don't know if one of you wants to take those questions.
I'll jump in. And so I'm just reviewing Vanessa and Abdul's questions. Thanks very much. So I'll just start at the top. So when VHAC was created, it was created by doctors Sarah Mark and Sharon Vippler back in 2020, and they were very intentional in terms of ensuring that our service maintained capacity. And so we are designed to be more of a short-term, like a low barrier access point. And it's less of a timeline where we'll follow people and more so a stabilization piece. So once say we're supporting someone to up titrate on opioid agonist therapy, once they're achieving an adequate dose, or they're demonstrating signs of clinical improvement and stability, we will support them to refer them to a long-term clinic, like an OAT clinic. There are times when we see people as like brief one-offs for bridging, but that's generally our model. Managing urine drug tests. So if we see patients in hospital, it will be done there. When we see patients in community, we do rely on our outreach and our colleagues and like the nursing team and things in community. So they are given a whole bunch of urine drug test cups, and they'll do those in the field and then provide us the results. And we try to be intentional with how often we're asking for them in terms of, is it going to impact our care decisions. And then otherwise, when we're meeting with people, it's always through a Fraser Health connection. So for example, our iHeart team, the team that's working with people in shelters or who are unhoused, they have Fraser Health issued phones. And so that's how we video. So we don't actually depend on any people to have their own technology at this time. So that's been okay. I think those were the main, and then just I
Yeah.
guess some challenges, as you can imagine, with technology. All the classics, like, do you have good connection? Can you hear them? With people in hospital, do you have a space, or are you basically video chatting with them in the emergency room? And then if you are not there, there's just always the added complexity of, in whichever environment you're reaching into, there are different dynamics you have to take into consideration. But generally, it operates like a regular appointment, and it's worked pretty well, I think, because of all the health authority support.
So, and I want to thank everybody who attended the session today. We had great turnout and good questions from everybody. I put the survey link in the chat, so if people have a chance to do that, to provide their feedback on the session, that would be very much appreciated. And I want to finish by saying thank you to all the presenters and who provide some really interesting and useful research. And I know that at least Mackenzie has said to please follow up with her with any further questions, but I'm sure all of our presenters are open to further follow-up and discussion. And thank you to everybody for your participation today. I hope you have a lovely rest of the conference.